Okay.
Please start, sir.
Good afternoon. At the outset, let me thank the organizers for giving me this opportunity to present before a very interesting topic called Galactoria. And I'm going to take you through an evidence-based approach on how to deal with a patient with Galactoria. But first, we'll ask ourselves a question. Does Galactoria loosely refer to hyperprolactinemia? And for that, let's have a look at a publication done in a reputed journal of our country, where the heading shows as hyperprolactinemia with normal serum prolactin, its clinical significance. This is a case report of a 31-year-old para-1 living one, last childbirth of 8 years, complained of amenorrhea for 2 years, prior history of normal menstrual cycles. Breast examination, of course, showed some secretions from both the breasts, which is not noticed by her earlier, and pelvic examination was normal. In view of the amenorrhea and Galactoria, she was advised serum prolactin and thyroid profile estimations and an ultrasound of the pelvis. Now, as you can see, prolactin levels were normal, which is euprolactinemic. Thyroid profile was also normal and a normal ultrasound study. But nevertheless, because of the breast secretion, she was advised cabergoline 0.5 milligrams once a week. She took this treatment for about 4 months and she continued to remain amenorrheic. Thereafter, discontinued treatment, and after a month, she bled a slight bit and thereafter presented with amenorrhea for 2 months. And lo and behold, she was pregnant. 7 weeks gestation, she had uneventful antenatal period and delivered a healthy baby. So basically, the discussion is isolated Galactoria with normal menstrual cycles and normal prolactin levels. So this should not be hyperprolactinemia, but euprolactinemia has been estimated to occur in up to 20% of women at some point in their life. So this should be actually Galactoria with normal serum prolactin, its clinical significance. And the issue is because of the heterogeneity of the prolactin molecule, which poses a challenging clinical issue with the gynecologists. So taking you through prolactin, some important facts. We all know it's a polypeptide hormone with 199 amino acids with a molecular weight of 23 kilodaltons. It's synthesized and by a pulsatile secretion from the anterior pituitary, from the cells known as the lactotropes. There are 3 types of prolactin: little, big, and big, big. And the little one has got the greater biological activity, and the unit of measurement is about 1 nanogram per mil, which corresponds to 20 milli international units per ml. The normal serum adult levels are about 5 to 27 nanograms per mils in females, and its highest secretory period during the rapid eye movement sleep, and the peak levels are between 4 to 6 or 5 to 7 a.m. And that is why it's very important that whenever you kind of request a patient to get a prolactin estimation, it should be preferably after 8:30 or 9 o'clock in the morning. And it can even go normal levels up to 30 nanograms per mils, and the circulating half-life is about 50 minutes. As discussed, it's synthesized and secreted from the lactotropes in the anterior pituitary. Hypothalamic dopamine inhibits prolactin secretion, and there are several hypothalamic releasing factors like the vasoactive intestinal polypeptide, thyrotropin-releasing hormone, and also estrogen, which also explains why pregnant women have elevated prolactin levels. It is impossible to go through the entire prolactin regulation in this presentation, but we all know the role of dopamine. So having discussed a confusing published case report, I'll take you through certain facts of Galactoria, give you a brief overview about nipple discharge, the causes evaluation and evidence management of Galactoria, some guidelines and some issues for the postgraduates to kind of refer to, and end with some key points and summary. So it's a non-lactational milk production. So milk production after 1 year of pregnancy or cessation of breastfeeding is called as Galactoria. It can be seen in nulliparous and postmenopausal women, and also sometimes in men. The incidence is variable, but can occur up to 90% of women with hyperprolactinemia. And that's why Galactoria and hyperprolactinemia are very, very loosely interchanged. And that was my question right in the beginning. About 30% of women who present to their doctor for a breast examination have some sort of nipple discharge, and it can be also seen in 7 to 10% of all breast symptoms. It's classified as normal or abnormal, depending on whether it's unilateral, bilateral, depending on the menstrual cycle, the quantity, color, or presentation, whether it's spontaneous or it's induced with some kind of medication, which I'll come to later on. The spontaneous or induced nipple discharge may be identified by either the patient accidentally or during a clinical examination, which happens sometimes suddenly while doing a mammography because of the pressure of the breast with the film. So there can be a kind of a discharge, and it can be categorized as normal, abnormal, or attributed to galactoria according to history and physical examination. So a nipple discharge is called to be normal. It's said to be normal when it is non-spontaneous and is usually bilateral, serous, and originates in many ducts. Multiple duct discharges are rarely caused by cancer. I repeat, multiple duct discharges are rarely caused by cancer. In cases not related to breast pathology, like mechanical stimulation, thoracic trauma, and medications are sometimes included in the differential diagnosis of breast discharge. So sometimes what happens, the patient is very curious to keep checking, and there's continuous mechanical stimulation of the nipple, wherein she must be told that you must stop this mechanical stimulation, otherwise it will not, this kind of nipple discharge will not go away, and if you stop it, it sometimes goes away. And therefore they should be advised to stop and avoid checking themselves every now and then. Abnormal nipple discharge is one which is non-lactational, persistent, spontaneous, and unilateral, usually located in one duct, and as it is usually spontaneous, it may actually disappear. And it may be gray, green, serous, or bloody. And even if bloody, it is usually benign. So just because someone has a bloody discharge from the nipple, please do not say it's cancer, because it's associated with only about 1.2 to 15% malignancy. So it's important to counsel and reassure the patient that most likely things should be all right. So this is a kind of a picture showing, a kind of galactoria, kind of a serous discharge and a bloody discharge, and of course, greenish discharge, which you sometimes get in fibrocystic disease. So there are a whole lot of kind of, just by looking at the discharge, you can kind of decide what kind of a discharge it is, and whether it's, kind of, whether it's galactoria, or whether it's kind of, whether you can think of whether it can be cancerous or not, whether it's unilateral, bilateral, as I, discussed a little earlier. So galactoria is typically bilateral. It originates from many ducts, and the discharge is milky. And this is typical in pharmacological galactoria, and discontinuation of the medication will eliminate the finding. So when galactoria is accompanied by amenorrhea, it is usually caused by hyperprolactinemia. It's a very important point. So galactoria with amenorrhea is usually due to hyperprolactinemia. So, however, when a patient has normal ovulatory cycles and galactoria, the prolactin levels are usually normal, or the patient is euprolactinemic. So we classify galactoria into two types: hyperprolactinemic galactoria and normo or euprolactinemic galactoria. So whenever there's any excessive nipple stimulation, as I spoke to a little earlier, including during sex or suckling, can cause a hyperprolactinemia and galactoria both. In the neonatal period, it's something important to know that the high level of estrogen from the mother can cause transient galactoria in the newborn, which is also called as witch's milk, which can come as a short note, and you must know what it all stands about. And we all are aware that during pregnancy, especially in the third trimester, the levels can go up very high, so there can be some amount of galactoria as well. And other causes of transient galactoria could be vigorous exercise, physical stress, etc. I will not go through the causes of hyperprolactinemic galactoria, because that's a class by itself. We know it could be either physiological or pathological. We know the stalk effect, the tumors, the pituitary lesions, the lesions involving chest wall, systemic disease. But which is most important, and we have to ask in the history, is medication-induced hyperprolactinemia. And if you see the list of medications which can actually cause galactoria, it is mind-boggling. And a lot of our patients keep looking into the internet and taking all sorts of these kind of non-hormonal medications, these herbs like anise, blessed thistle, fennel, fenugreek seed, marshmallow, nettle, red clover, red raspberry, etc. We can actually cause galactoria. So a history is very important. We are all aware about antidepressants, anxiolytics, some antihypertensives, etc. But what is also important for us to know, that antipsychotic and GI promoting agents, they block the dopamine receptor on the pituitary lactotropes, thereby decreasing the normal inhibition of prolactin release and thereby causing hyperprolactinemia. So it's important for us that many illicit drugs and herbal supplements, in addition to the standard medication which we keep reading, can also cause galactoria. Just a slide on Chiari-Fromel syndrome, which we all know is a rare endocrine disorder that affects postpartum women and is characterized by galactoria, anovulation, and amenorrhea. Symptoms persist for long, more than 6 months postpartum, and it very rarely can actually result in uterine atrophy. But it can also resolve spontaneously and hormone levels and reproductive function return to normal. So we know about idiopathic, hyperprolactinemia, no causes, sometimes found. Again, we have to follow them up. But, where there's really sometimes, very kind of irritating galactoria not going, we should, look at a CT scan, an MRI of the brain, and especially ask for a very high-end CT scan with a 3 Tesla machine with 1 millimeter cellular cuts. Because if you don't get adequate cellular cuts of 1 millimeter, around 1 millimeter, if it's more than that, you may actually miss out on these very small microprolactinomas, which can be the cause for this so-called idiopathic hyperprolactinemia, which actually is not. And we have seen that many times when these old machines go to the districts and the district brain, MRI pituitary comes as normal. Actually, when you use these high-end machines of 3 Tesla with 1 millimeter cellular cuts, you will actually pick up a prolactinoma, which was not there earlier. So when we talk about evaluation of galactoria, we can evaluate based on, we kind of distinguish them from pathological nipple discharge, which can involve breast tumors. We all know what is galactoria. It's bilateral, multiductal, it can be milky, it can be various, even the discharges can be of different points. So we have to make sure that we don't mix one with the two. And well, we have the Sudan 4 staining for fat droplets in the nipple discharge, which can confirm the diagnosis, which, whether it's we are dealing with galactoria or, just another kind of breast discharge. So based on the various kind of clinical symptoms, we can think of the possible etiology of galactoria, whether it's galactoria in the neonatal period or whether it's associated with certain headache, visual disturbances, decreased libido, tiredness, and things like that, which we can actually have the different diagnoses of hyperprolactinemia, hypothyroidism, thyrotoxicosis, etc. And we can go down the list and actually think clinically what could be the cause of galactoria. Physical findings, again, will give us some kind of idea with poor growth to hyperpituitarism, if it's gigantism or acromegaly, a pituitary tumor, etc. Again, we can, kind of plan both clinically as well as both by the signs and symptoms and also by the clinical findings. And we have a lovely algorithm where we start with the nipple discharge, whether we rule out breast pathology, if it's galactoria, whether there is any, elevated prolactin levels. If it's a euprolactinemia, we really don't have to bother much, reassure the patient. If it's yes, then we have a whole lot of kind of causes which will rule out, whether it's a thyroid issue, whether it's pregnancy, whether it's, there's a renal disease, whether it's medication induced, and if there are no causes found, we can definitely do an MRI and pick up a hyperprolactinemia, a prolactinoma, which is hitherto missed, or you diagnose one and then treat with a dopamine agonist, or very rarely surgery. And then if it's normal, we again go back to idiopathic hyperprolactinemia and reassure the patient. So coming to management, once we exclude the breast, pathology, we actually treat only bothersome galactoria, and if not, we just kind of reassure the patient and monitor her condition, because most galactoria associated with hyperprolactinemia treatment is obviously classified based on the underlying cause. And the medications we are well aware of bromocriptine and cabergoline. And although bromocriptine is a long used drug, we are very, very comfortable with the use of cabergoline now. And I think it goes without saying that most of us have shifted to cabergoline. The only thing which sometimes people do speak about is that bromocriptine has got a better kind of safety database compared to cabergoline, especially when someone trying to get pregnant. But I personally feel in our clinical practice now, cabergoline is doing just as well. And we all know that the levels with cabergoline come down dramatically. We have to give it once a week, so the compliance is much better than bromocriptine. So, normal prolactinemia, galactoria, just a few words on it again. If the galactoria is not associated with breast tenderness and swelling, it is not particularly bothersome. Just reassure the patient, do nothing else. And again, no mechanical stimulation. And that's very, very important to advise them. But if it becomes bothersome, I think a low-dose dopamine agonist like cabergoline will definitely help us to resolve the issue in a couple of months, and we have a happy patient, and just taper off the drug. For some of the clinicians who are interested, there's a wonderful guideline in the Journal of Clinical Endocrinology and Metabolism. And this is a guideline by the Endocrine Society. In 2001, I think it's time that it's revised, but this is such a wonderful guideline. It'll be wonderful if some of you can even look at it and go through the guidelines on how to treat hyperprolactinemia, which I've gained a lot when we talk more detail on a topic, let's say on hyperprolactinemia, not on galactoria. Another is a wonderful systemic review and meta-analysis by Wong et al. which is published in Systemic Reviews in 2012, where again, just imagine 8 randomized, 178 non-randomized study over 3,000 patients meeting the clinical criteria. And it was very clear that cabergoline was more effective than bromocriptine in reducing hyperprolactinemia, amenorrhea, oligomenorrhea, and galactoria. So you know, cabergoline is definitely the medicine of choice now. And the author's conclusions were obviously cabergoline proving more efficacious than bromocriptine. So this systemic review is also another great one to look at. So I'll end with certain key points. And galactoria is commonly caused by hyperprolactinemia, which we know 90% of it, especially when it is associated with amenorrhea. Hyperprolactinemia is the most often induced by medication, and that's very important in the history. It can be associated with pituitary adenomas, androcellular or supracellular lesions. Less common cause of galactoria, as in the algorithm I discussed, for thyroid, hypothyroid, renal insufficiency, pregnancy, and nipple stimulation, mechanical stimulation. After pathological nipple stimulation is ruled out, patients with galactoria should be evaluated by measurements of their serum prolactin. MRI of the brain should be performed if no other cause of hyperprolactinemia are found to rule out that it's not an idiopathic hyperprolactinemia, but with, you know, as I mentioned, I repeated it not once, but twice maybe about the 3 Tesla machines with 1 millimeter cellular cuts. And patients with prolactinomas are usually treated with dopamine agonists like bromocriptine or cabergoline, and it's cabergoline now, and surgery or radiation therapy is rarely and thankfully rarely required than the days when we were postgraduate students. So medications causing hyperprolactinemia should be discontinued or replaced with a medication from a similar class with low potential for causing hyperprolactinemia. And normal prolactinemic patients with idiopathic non-bothersome galactoria can be reassured and do not need treatment. However, those with bothersome galactoria, as I told you earlier, they do respond to a short course of low-dose dopamine agonists like cabergoline. Instead of 0.5 milligrams, it could be 0.25 milligrams once a week, and then half that tablet to 0.125 milligrams, and then slowly taper off. Another good read is the Evaluation and Management of Galactoria of 2012 in the American Family Physicians. So to summarize, diagnose the etiology of galactoria before initiating any treatment, control symptoms and ascertain the desire of the patient. First line of therapy is cabergoline. Bromocriptine has now become the second choice, and it's a team therapy which must involve an endocrinologist, because they will be able to guide you. They're the ones who are reading with the latest guidelines on all their endocrinological problems. So it's always good to kind of tickle their brain and really use their help whenever we are looking for some kind of benefit for our patient to the maximum. But remember, 2 things. Patients with isolated galactoria and normal prolactin levels do not require treatment if they are not bothered by galactoria, do not wish to conceive, and do not show evidence of hypogonadism or reduced bone density. A very, very important point. And the second one is prolactin levels are usually normal when a patient has galactoria and normal ovulatory cycles. I'm extremely grateful to Dr. Shanta Kumari, President of FOGSI, Dr. Rakhi Singh, the chair of the endocrinology committee of FOGSI, and all my respected chairpersons and senior teachers here for giving me this opportunity to speak on a clinical topic, which is not often, treated the way we usually should, because we always only think of hyperprolactinemia while we forget galactoria, taking you back to that first published study, which said hyperprolactinemia with normal serum prolactin, actually should have been galactoria with normal serum prolactin. Thank you very much. And I hope in the last 15 to 20 minutes, I've managed to cover most of my presentation objectives. And I'll end with a great thanks to all of you and greetings from Kolkata. Thank you very much.